Need an answer to a medical question? Join us for our viewers' favorite show, which provides our audience the chance to have their medical questions answered by our Prairie Doc and guests. Ask Anything, tonight on Call with the Prairie Doc. Major funding for On Call with the Prairie Doc has been provided by
At Avera, our nationally recognized health system will be right here with you, with care and coverage. Hello possibility. Hello healthy. Hello life. Avera, moving health forward.
Larson Manufacturing is proud to support On Call with the Prairie Doc as it continues to open doors for important medical information. And with the ongoing support of these individuals and institutions, Brookings Health System, South Dakota Academy of Family Physicians, Ophthalmology Limited, Avera Medical Group Brookings, Avera Heart Hospital, First Bank and Trust, Dakota Allergy and Asthma, Monument Health.
Tonight, we continue to provide trusted health information with one of our viewers' favorite shows, Ask Anything. Tonight, On Call with the Prairie Doc. Welcome to On Call with the Prairie Doc, health information based on science, built on trust. I'm your Prairie Doc host, Dr. Jill Kruse, and welcome to our 23rd season. Tonight, we will start with one of our viewers' favorite shows, Ask Anything, where viewers can call in, email, or message us any medical question they have. As we start the new season, we are reminded why it is so important to continue the mission of Prairie Doc programming. Having access to science-based health information is critical, especially in rural communities where resources and services may be more limited. Trusted health information plays a pivotal role in improving community well-being by promoting knowledge and healthy practices across all age groups, addressing a wide range of health issues from chronic diseases to mental health and influencing policy and economic outcomes. Without accurate information, individuals may make uninformed decisions about their health, leading to potential complications and worsening of existing conditions. Prairie Doc knows that having access to trusted health information can help bridge the gap between individuals, communities, and healthcare providers. It can supply individuals with knowledge and tools they need to communicate effectively with healthcare professionals, ask informed questions, and advocate for their own health needs. By promoting health literacy and empowering individuals with accurate information, communities and patients can work towards achieving better health outcomes and reducing health disparities in our state. This evening, we are joined in the studio by Dr. Andrew Ellsworth, Dr. Debra Johnston, and Dr. Kelly Evans-Hullinger from Avera Brookings Medical Clinic. Welcome, everyone, and thank you for taking time to answer questions this evening. So we will start, Dr. Evans, since we're starting the new season, could you tell our viewers a little bit about yourself?
Yes, I would love to. It's our first time back in the studio after a break. The studio's been remodeled a little bit. So I'm a general internal medicine physician. I see adult patients in Brookings. I'm from Brookings originally, so I'm back in my hometown. My first encounter with Prairie Doc programming was when I was an undergrad student, and I was waiting tables at the local sports bar and happened to wait on Dr. Holm, who I knew, he's from my hometown. And he got wind that I was thinking about going to medical school and asked me to come shadow. So I show up to a shadow, I think I'm gonna be a fly on the wall in clinic. And of course, you probably all know what happened next. He said, get in the car, Evans, we're going to the radio station. And I was horrified. But now 8 years later, and I guess what are we in our four? Yes, more than that. But now 8 years into this, and 4 years into being one of our co-hosts. The mission is very dear to me now too. I think like it was to him.
Excellent. Are you going to be dragging students to the show?
Anytime I can, yes, of course.
Excellent. All right. Well, Dr. Ellsworth, your turn. Introduce us to the community and tell about how you got involved with Prairie Doc.
I am a family doc here in Brookings. Been here 12 years, and it was one of those things where I wasn't here a year or two before Dr. Holm asked me to be a guest on the show. And then there was a time or two more, I don't know how many more times, but then once he was trying to ensure his legacy, which he has, and put into place the team, not just the four of us, but a big team to help make it happen. And so that's been great to carry on the vision and how I feel like it's growing strong.
Yes,
so.
And a large in part to all the work your wife has also done. So share Laura and her.
My wife Laura hosts the radio program, and Joan Hogan had been the original host of that, and then a few years ago, about the same time, Laura started doing that, and this year it is transitioning over to South Dakota Public Radio, and it's been recorded, and the first show will be played this Sunday, and it'll be Sundays on South Dakota Public Radio at 6 a.m. and 1 p.m. So you don't actually have to get up really early Sunday morning to hear it.
And it'll be a podcast too.
And a podcast as well, thank you.
Yes. All right, well, last but not least, Dr. Johnston.
Almost last.
Almost last.
So I got involved, I'm a family practice doctor, like the two people on either side of me, and I finished my residency here in Brookings. My last 2 years, Rick was one of my mentors. So I at least had a little bit of medical experience before he put me on the radio with him. And so I have been involved with the show almost since its inception in one form or another, and I think Rick would be proud of how it's continued without him. So, yes. Dr. Kruse, you don't get by without introducing yourself and telling us how you got involved with this either.
All right, sorry, yes. So I'm the host of the show tonight, but I've been involved with Prairie Doc since I came here about 11 years ago. Rick first had me doing one of the roll-ins, one of the pre-recorded segments, just to see how I did. I think that was my screen test, and I must have done well. He found out I did a lot with community theater growing up and through college and beyond. I've gotten really involved with community theater back here in Brookings. So he decided that he wanted to do a show on medical ethics and talk about Frankenstein and Mary Shelley for a Halloween special edition of Prairie Doc, and somehow conned me into dressing up like Mary Shelley and showing up at Van Fishback's house to do a recording and then host the show so he could be the guest because he was so excited to talk about that topic. And I think it's kind of gone from there. So
it's been a great thing to be a part of. It's a great legacy for Rick, and it was a great opportunity for the state of South Dakota and the community.
Yes.
Well, and a few years ago when we did our anniversary show, it was nice hearing the stories of the impact it can make. And honestly, that's all. It's just 4 docs and more, all the other volunteers giving their down-to-earth, honest advice, and there's no pressure by any pharmaceutical company or healthcare system or anything, and that's it.
Nobody's making any money off of this.
Right, volunteer.
There's no hidden agenda other than helping people be healthy.
I don't know, I'm collecting a collection of these coffee mugs every year.
I do have quite a collection of coffee mugs.
This way is nice.
Yeah.
That is my biggest payment, is a new coffee cup every year.
New coffee cup, yes. And so, given how much you don't like coffee, that's hot cocoa mug.
Yeah, it's my hot cocoa mug.
Yes,
So.
yes.
All right. Well, before we start our conversation, we invite you, our audience, to submit your questions for tonight's discussion about any medical topic or issue you or a loved one may be having. Viewers can contact us 3 ways. Call 1-888-376-6225. Send an email to ask@prairiedoc.org or ask on our Prairie Doc Facebook page. We will work to answer as many of your questions as possible given the time available. Sometimes we receive more questions than we can cover, and we apologize if we do not get to your question. Your question will remain anonymous, and no information is saved. Viewers can leave their name, email, or phone number to be entered into a drawing for one of our Prairie Doc publications, Perspectives from the Prairie, but it is not required to submit a question. The winner will be drawn and announced at the end of this program. So let's get to questions. All right. So there are already 10 questions here, so it's going to be a busy show.
It's one of my favorites too. I love this show.
It is. It's such a grab bag of questions.
Yes, it's so fun.
So we'll start at the top and work our way down.
All right.
So from an email, does CBD oil or gummies really work for pain?
Don't we wish we knew?
Yeah, I mean, people ask about CBD and THC for that matter, and there are just so many unanswered questions that it's very difficult for us to give an intelligent answer. All we have is kind of anecdotal information, which is probably meaning, stories from people who have used it, which is probably what this caller has in their pocket too. So we really don't know. Yeah.
Yeah, and we don't know the long-term consequences either.
Right.
It may be helpful, and if it works for someone, great. And hopefully there's not long-term consequences. They're hopefully, and they are studying that.
Yeah. I think in 5 or 10 years we'll have a lot more answers, but we just don't at this point.
Exactly. All right.
It's something that I don't, I mean, again, we don't necessarily know the long-term consequences, but CBD oil in particular, I don't really object when my patients use.
Especially topical.
Especially
topical is
topical.
probably the most safe route to, in theory, use that. So,
I mean, when we compare it to narcotics and we know problems that causes, or let alone NSAIDs, and non-steroidal anti-inflammatories such as ibuprofen or Aleve or whatever, and those can cause problems too. So anything you put in your body, there's going to be some pros and cons.
Exactly.
And I wish we knew more about it with CBD oil. We at least know what we're getting into with NSAIDs, but.
All right. Well, very thorough answer for a short question.
Very thorough non-answer.
But we got to keep going because they just keep coming in. So next from an email says, what causes COPD? So maybe we should first define what the letters mean, because there's a lot of acronyms in medicine.
Yes.
So COPD, chronic obstructive pulmonary disorder.
Yeah. So COPD is, you might hear it also called emphysema, chronic bronchitis. These are all kind of the same thing that we're talking about. This is a chronic lung disease. So if you've had symptoms for 3 days, it is probably not COPD. It's a disease. The most common reason people get this is smoking, of course, but far and away. There are some cases in which smoking is not involved, but most people who have COPD do have at least a history of smoking. The small airways down, if you can think of the airways in your lungs, the trachea then branches, and then you get these smaller and smaller little branches down in the lungs before you get to the air sacs. Those get sort of inflamed, enlarged, and really what happens is your lungs have a hard time emptying, actually. It's exhalation in which you have wheezing and tightness, a lot of mucus production in a lot of cases of COPD. There's a little bit of a spectrum of symptoms, but it often involves sort of long-standing difficulty breathing, chronic cough, sputum production, and then different things can flare it up. So if you get a cold virus, that might flare it up. If you get influenza, that'll definitely flare it up. Sometimes, COVID definitely will. Smoke, we saw this a lot with some of the wildfire smoke in the last couple of years. You might flare it up, and sometimes it puts people in the hospital. And so I would say I think the question was about the cause. So I'll stop there.
See, this is why I love having Dr. Evans on the show. I can just sit back and listen to her lecture. I always love it when you have med students because you're such a great teacher. So
thank you.
Excellent. This one is a little bit longer question from an email regarding their eyes. The patient had surgery for vision and their eyes are doing good, but the ophthalmologist discovered some unusual specks on the eye. Lately, their question is they've been having their eyes burning and their vision more blurry. It feels better if they close their eyes, and their eyes are dry, but the drops don't seem to last. They wonder, is that a problem? Should they be contacting their ophthalmologist or looking into this further?
Short answer, yes, they should contact their ophthalmologist. It is common to have dry eye symptoms, especially after eye surgery. And maybe it'll get better with time. But yeah, LASIX and other eye surgeries, you can have more dry eye. And so, yes, maybe it's frustrating that the eye drops don't last, but a lot of them you can keep using, and then hopefully with time it might get better, or maybe see the ophthalmologist, eye doctor, and there's perhaps some other solutions that they can prescribe.
Or a different drop. A lot of the wetting drops, things like artificial tears, Refresh PM, they can be used over and over and over and over again. And a lot of people will come in and they'll complain, well, my eyes are just watering and watering and watering. And it's because they have dry eyes, and that doesn't make any sense, because my eyes are watering all the time. They're wet all the time. How can they be dry? But that's the problem. They're using the tears to try to replace that lubrication. So again, long answer to convey short information, which is use your drops more, assuming they're not a steroid drop, and go talk to your eye doctor.
I think a lot of patients, when they come into clinic for an eye complaint, there's of course, conjunctivitis and simple things that are easy for us to diagnose in clinic. But the reality is, a lot of eye conditions, we do not have the tools to actually examine the eye well enough. So if you have vision change, if you have eye pain, or many of these things, I often will, if a patient calls in, or even if a patient comes in, if I hear a certain set of complaints, the answer is we have to get you in for a real eye exam where they can use a slit lamp and do a real retinal exam, because we don't want to miss certain things in the eye that I can't see.
Yeah, and things we can't measure, like intraocular pressure, checking for glaucoma, doing dilated retinal exams. There's a lot of stuff that they have a lot of cool tools at the optometrist and ophthalmologist offices that we just don't have access to at all. So yes, I think very good to, it sounds like they already have connections with an ophthalmologist, so I would definitely use that resource and let them know you have concerns. So, all right.
Good.
Well, from reducing anxiety to helping with physical rehabilitation, it's clear that therapy dogs are a valuable resource. Prairie Doc spoke with one volunteer whose furry companion makes an impact everywhere he goes.
This is Winston. He's a 7-year-old English cream golden retriever and is a therapy dog for patients at Sanford hospitals. Ashley Simonson is a volunteer for Therapy Dogs International. She first noticed the organization at a library in Sioux Falls.
And I noticed at the libraries, actually, that some dogs would come in and sit with kids, and the kids could read to them. And I was very curious. I said, how do you get involved in that? I asked the librarian, and they kind of gave me the whole, this is the Therapy Dog International is the company that we use to have volunteers come in and provide this service. And I thought, well, Winston would be perfect for that, because he loves to just lay down and be talked to.
Simonson signed Winston up for training in a hospital setting. It was a 4-week program that helped Winston acclimate to different situations, like kids pulling on his tail, to loud noises that could frighten him.
The big thing is just being able to trust that if I don't have my eye on him for a second, I'm not worried at all that he's going to try to go towards anything or leave. And it is kind of funny, when he has his bandana on, it's like he knows he's at work.
Winston passed with flying colors, although his hardest test was ignoring food on the ground.
We had to take a walk over chicken nuggets that were spread on the floor, and he couldn't look or eat them. And that was my worry, that he wouldn't pass it that time, but he did a great job. He walked over, and then I was sure to give him lots of his own treats after that.
A normal visit for Winston starts at the hospital, going from floor to floor, visiting patients who want to see him. Winston doesn't just visit patients, but also nurses.
He really enjoys going to nurses' stations. They tend to give the best belly rubs.
Simonson says she loves bringing Winston to hospitals.
Here, Winston.
Oh, is he? Oh, did he try to give you kisses?
Because he brings joy and happiness in what may be a sad and scary time.
We walk into the lobby and everyone's like, oh, it's a therapy dog. And then, their first question is always, can I pet him? And I said, absolutely, that's his job. He would be offended if you didn't.
10 seconds. Well, what's the difference between a therapy dog, a service animal, and an emotional support animal? Because those are three very different, cuddly.
Very, very different things. So a service animal, or usually a service dog, kind of by federal definition, a service animal can be a dog or a miniature horse, actually. And that is an animal that has been specifically trained to assist an individual with a specific problem. So it might be the situation everybody is familiar with is the seeing eye dog. So that is a dog that has been specially trained to help a person who has limited vision navigate their world. It might be a dog that has been trained to help somebody who has seizures, to recognize that and to help that individual get to a safe place, or a person who has diabetes to recognize that falling blood sugar. So that animal has to have specific training to help an individual with a specific task. They may have been trained by an external organization, they may have been trained by the individual. That isn't specified by legislation, but the fact that that animal has to have a specific role is what makes them a service animal. An emotional support animal is my pet that helps me calm down, that helps me feel safe, that gives me emotional support. That is not a federally protected role that individual or that animal has. And then a therapy animal has had specific training to provide that support to a wider range of individuals. So that is an animal that has also had some specialized education training so that it can handle a range of circumstances. They might go to the nursing home and see all those elderly people in their scary wheelchairs and with their scary shouting because they're all deaf, or whatever it is. That is also an animal that serves not just an individual but a wider range of people. So there is truly a difference.
Mm-hmm. Mm-hmm. Yes, actually, on my last trip, there was a therapy dog in the airport in Minneapolis.
Yes.
And we got to sit down and pet this dog and say hi and help with the little stress of travel. Made me feel better. So,
yeah.
But very calm, relaxed dog.
Yes.
Complete opposite of my personal pet.
It's amazing what animals can do and what they can be trained to do and how they can help us.
Amazing,
Absolutely.
yes, exactly.
I did not know miniature horses could be service animals.
Yes.
Miniature
Now I know.
horses. Now you know. There you go.
There. It might be hard to fit on a plane, but
It might be hard to fit on a plane, yes. And obviously there are certainly not all roles that animal can play, but if you have somebody whose mobility is part of their issue, that miniature horse is going to be better suited than most dogs would be to helping that person get up off the floor or pulling that person.
There you go. And then there's been emotional support animals of all flavors, including a gentleman in Florida with an emotional support alligator.
Yes.
All right, well, we have lots of questions here, so we'll try to keep at them. So a viewer called in, a 73-year-old female, lost her sense of smell a few years ago, long before COVID. Did see an ENT doctor who tested and confirmed that they were unable to smell, said 27%. Tried steroids, didn't work. Is there anything else they could try?
So the loss of sense of smell was a thing that happened long before COVID too, and different viruses can trigger it, including COVID and chronic sinus infections. There's a variety of causes, and idiopathic unknown reasons can be the cause. But there's not a defined treatment that for sure can cure it. There's retraining that you can do either professionally and through an ENT or some other provider. But even just, it might be helpful anytime you're walking by peppermint or a certain flower or something that you remember that smell, to smell it and think in your head what that smelled like, and over time you can retrain the circuitry in your brain to regain. Now, it's not a guarantee, but there is some hope in some of those therapies to retrain your sense of smell.
All right, excellent. Well, next question. What is the latest treatment for tinnitus? I've had it for 9 years. They ring 24/7. No one seems to have an effective treatment.
That's the truth.
Yeah,
Yes.
it is, unfortunately.
Amen.
It's amazing how hearing aids can
Yes.
hear it sometimes. Hearing loss is the leading cause, and so hearing aids, for some people, do the trick. But unfortunately, it's not always.
Kind of like noise canceling headphones. If it can figure out what the
Right.
pitch of it is, sometimes it can cancel it out. Apparently, USD is doing some research on this currently, so that's very hopeful for future, but right now, not much. There are a few techniques that people can try that kind of help mask it. If you just look up tinnitus and tapping, there's a lot of YouTube videos that kind of show this technique where you kind of put your hand and snap the back, kind of those little bumps on the back of the head. And if you do that several times, it may give you a brief pause. I've tried that, and that actually helps the ringing I have in my ears at times, but it's not permanent. It'll be back, later that day or the next day. But if you need it, like going to sleep, that's the time that I would mainly use it, because that ringing can sometimes be distracting, make it hard to sleep. I would do that, get to sleep. When I wake up in the morning, it's back, but at least it was easier to get to sleep.
Sometimes you can use a masking technique too, where you have the fan or the
Some
radio
white noise.
white noise
Exactly.
that kind of covers that up, that your brain can figure out how to ignore a little more easily. And some people end up on medications because it's driving them nuts. And the medication doesn't help the ringing, but it helps the driving me
Helps you
nuts.
cope with it a little better.
Yeah.
Yeah, so. All right, well, next question. I have diabetes, and lately my feet are always freezing. Summer, and I'm wearing socks to bed. Is there anything I can do for this?
Yeah, I mean, it's an interesting concern. Certainly, I have patients not infrequently come in and say my feet feel super cold or whatever, and we don't find that anything's actually wrong, and it's hard. I don't have a good explanation. However, the presence of diabetes begs a few questions. Of course, we care about things can happen to the feet. So a couple considerations are sometimes the sensation of cold might actually be a nerve sensation that's abnormal, like neuropathy. So getting some sensation tested, I'd be interested to know that information. And then of course, we'd want to know about circulation. Another really important feature, circulation to the feet in people with diabetes. So I think getting your feet examined is very important if you're having a new complaint like this. If it's neuropathy, maybe medicines that treat the neuropathy actually might make it less bothersome. If nothing major is found, you might be stuck with your warm socks, and that's okay too. But I would get it checked out.
And our metabolism changes as we age, and it may be slowing down, and sometimes we become colder easier, or hypothyroidism, low thyroid, and that's where the workup for various causes for neuropathy would come through too. But.
And on that note too, we really worry about the feet, because if your feet are cold and if you can't feel them very well and if they don't have good circulation, there's a real risk of injury that doesn't heal very well, and this is why a lot of people with diabetes end up with amputations. So get this checked out.
Yep. All right, next question. Suggestions for meralgia paresthetica. That's a long word, big fancy Latin name.
It's a long word that means specific numbness in a specific part of the thigh. It is a skin nerve, and I just saw a patient who had it today, as a matter of fact. It's not something that I encounter all that often, but it's kind of fun when you do and you know exactly what it is, and then you have to remember, okay, now what that was, paresthetica, try to remember the nonsensical Latin word for it. It is often associated with obesity. It is often associated with pressure on that skin nerve. So getting rid of the pressure on that skin nerve, maybe you're a law enforcement officer who always has this big heavy belt hanging on that, can be helpful. And sometimes just knowing it's not a stroke, there's nothing wrong with your back, is enough. And sometimes there's topical creams you can use to help with the sensation or other neuropathy type medications you can use.
Yeah.
So looser fitting clothing.
Not wearing tight belts. Purses, women's purses is a notorious banging against your side as you walk. Can cause that. Men, thick wallets, I've seen men get that. And then I've seen truck drivers, because it's right where your seatbelt, the hard part of the seatbelt hits on the thigh, can lead to meralgia parasitica. So
It happens. It
happens,
somewhat
yeah.
common.
All right, next caller says they need a hip replacement, not able to do it for several months. Is it okay to put it off until it's more convenient?
Generally, yes. Yes. I mean, most hip replacements are for arthritis, and I tell people the right time is when you say it's the right time. So.
Excellent. All right.
Good chance they might wish they had just done it sooner once it's all said and done. But
most
yes.
people recover pretty quickly from a hip replacement. I hate to,
make any promises.
But a lot of people recover quite quickly from that surgery.
That first month or a few weeks are sometimes rough. It's a transition, but it gets better.
Worth it.
I think, a year afterwards, they wonder why they didn't do it sooner. But it's usually you have to be miserable. I always say it's kind of like pregnancy. You'll have that baby when you're so sick of being pregnant that you'll literally do anything not to be pregnant anymore. And when you are so sick of that pain in your hip that you will literally do anything not to have it anymore, that's the right time.
All right. Next caller says they have terrible sleep issues. Hard time falling back asleep after waking up in the middle of the night to urinate. They're not taking any prescribed medications, but they take melatonin, Sleep 3, and Ultril. Concerned because the directions say don't use long term. So, advice for this person that can't sleep.
This is such a tough problem. Insomnia is really difficult. Honestly, we have very little that promises to help chronic insomnia. Couple tips I would have. I mean, I think if you're getting up, especially if you're getting up multiple times in the night to urinate, investigating whether there's something that could be done about that may be helpful. Maybe if you don't wake up in the first place, you don't have trouble falling back asleep. I urge, it depends a little bit on the age of the patient. I see a lot of patients over 65 and much older. I urge patients to really stay away from sleep products that contain diphenhydramine or Benadryl, which a lot of over-the-counter sleep aids do. They tend to make people groggy in the morning. They actually worsen cognition in the older people. So I would, like a lot of unfortunate things. We have more and more evidence that actually the best treatment for insomnia is a very special type of cognitive behavioral therapy, which the problem is it's not that easy to get that type of therapy access-wise. But medications, I measure my promises on how we can help people with medication. So learning strategies to kind of turn your brain off once you wake up is probably the best long-term strategy.
I'd add that sleep apnea is a big reason why people wake up too. And there's so many times where I'm waking up so often it's because I have to pee, but actually sleep apnea is waking them up often, and then they're just going to the bathroom because they're awake.
So making sure you don't have some other sleep disorder is important.
And paying real close attention, this kind of plays into your cognitive behavioral therapy, to all those sleep habits. Bed is for sleep. Don't do other things in bed. Don't read in bed. Don't scroll on your phone in bed. Put the screen away well before bedtime. Those of us who have trouble sleeping probably shouldn't have their coffee like Dr. Evans and I do until all hours of the night. All of those kinds of behavioral things that are just super important. And the more trouble you have with sleep, the more important it is to be really rigid about following those rules.
And exercise. Sleep naturally changes for people as they age too. I mean, I have patients that come in and say, I used to sleep 8 hours every night. Now I only sleep 5 or 6. And my first question is, well, how do you feel? Like, if you feel okay, then that might be okay. We don't have to fix sleep just to get a certain amount of hours. It really depends on how you feel like your brain has rested to some degree.
Absolutely.
Exactly. Excellent. Well, it can be difficult to recruit healthcare professionals to rural areas for a variety of reasons. One opportunity to provide future health professionals a rural experience is a summer internship for college students. Prairie Doc talked to reps about how this experience encourages students to stay rural.
Melissa Edswold is the Associate Director of the Rural Experiences for Health Profession Students, also known as REPS. Its main purpose is to give college students in a health major the experience of living and working in a rural town in South Dakota.
So they get the opportunity to have a 4-week, 3 or 4 week, they can choose actually, clinical experience where they get the opportunity to go in and shadow in their field of study. But then while they're also shadowing during their field of study, we're rotating them in to the other areas of healthcare.
Students enrolled at SDSU, USD, Mount Marty College, and Dakota Wesleyan University are eligible. When they apply to the summer internship, only 30 students are selected. Those selected are placed in small towns under 10,000 people where they help in the clinics and in the community.
So they're not just seeing the healthcare side of it, they're seeing what those people are doing inside their rural communities and how that all works together and to promote that patient care and more or less give them that holistic view of not just healthcare, but healthcare and living in a rural community.
Edswold says some students that didn't picture themselves working in the rural area opened their minds because of this experience.
I kind of chuckle sometimes on some of them. Are like, I never would have thought about going rural. And after this experience, I have truly decided I think this is where I want to be.
Students living in rural areas get to experience the bond of a small community.
One of the other students this summer was unfortunately in a site that had suffered some tragic events and really learned how that doesn't affect just the team that helped them. It affects a lot of people throughout the process. You know, if your first responders, your EMTs, all of that. And they thought it was pretty cool how the community all came together and rallied around all of them to support them.
Edswold tells students working in a big city doesn't feel the same after working and experiencing the joys of a small community.
I had told a student earlier this year, we were having a conversation, and I said, if you're not okay with your patients walking up to you in the grocery store and just saying, hi, how are you today? Rural is not for you. But if you really enjoy that aspect, then rural is for you because you are going to get that day in and day out.
Well, what does a small community atmosphere feel like compared to a big town? And we were just talking about this with our Prairie Doc assistants before the show about practicing rural versus large cities and kind of comparing and contrasting places we were during training. I mean, I was in Detroit, I was in Wichita, I was in St. Louis, and then I came back.
You were in a smaller community.
I was much smaller than this.
Before you came to Brookings,
yeah, my
right?
first 5 years of practice after residency was in Tyndall, South Dakota. So it's a very small town, about 1,200 people. Hello, all my check days friends, and miss you guys.
I really admire those real small town physicians. It's a difficult job, but I think also very rewarding for a lot of those people.
Very rewarding. I miss those people, and we still go back and visit. So, but yeah, definitely rural is a different level and skill set. I remember talking when I was on rotations with a neurosurgeon, so super smart, super prestigious doctor. And he said, what do you want to do? And I said, I want to be a rural family practice. And he said, oh my gosh, I could not be that smart. I could never do that. How can you do that? I was like, what? He's like, you have to know everything as a rural family doctor. You have to be on top of your game, and you are the doctor for that community, and they're looking to you. He's like, I just do my little narrow thing and I can go home and I have partners, but you're it. So, I mean, very rewarding, but does take a lot of dedication and work to stay on top of that so you can give the best care to your patients.
Well, I'm glad we have that program and programs like that, because we need doctors and nurses and respiratory therapists and everything else to help fill in the rural areas that are becoming shortages of EMTs and you name it, we need them.
Yeah, because it's a long way from Chamberlain to Sioux Falls.
Yeah.
All right. Well, on to more questions. So, what do you think about long-term infections of the middle ear? This person has been on antibiotics and steroids. Dr. Johnston?
I think that this is a major issue, and if they're not already seeing an ear, nose, and throat doctor, they need to be seeing an ear, nose, and throat doctor.
And imaging.
And imaging,
yeah.
Absolutely imaging. They need a CT. And
why is this not getting better?
Why is this not getting better?
Granted, a person comes in and they go to an urgent care and they give them an antibiotic, and then they go in. So they also need to make sure they're seeing either hopefully if they have a primary care doctor, or get in with someone that can evaluate them more thoroughly and refer them if needed.
Yeah, and I think that urgent care is a wonderful thing, and it's a very valuable thing. But if all you're doing is going to see the urgent care person for the same problem over and over again, whether it's your recurrent bladder infections or your recurrent pneumonia that maybe is actually COPD, but the person who sees somebody different every time isn't going to have somebody recognize that there's something else going on here. So go see your primary care doctor and talk about getting in to see your nose and throat doctor.
Is warranted.
All right. Well, we have 12 minutes and 12 questions. So either we go into lightning round, or we remind our viewers that any questions that we don't get answered here on this show, we can answer on the radio show. So there is the bonus round if we don't get stuff. So I love this conversation. I don't want to limit our answers. So never fear, we will get your questions dealt with. So next one, what causes sciatica and how can you treat it?
Dr. Ellsworth.
A lot of times we're dealing with some arthritis in the low back and the lumbar spine and degenerative disc disease, and in a nutshell, maybe it's kind of putting pressure on a nerve somehow, and inflammation. And sometimes physical therapy can be helpful. Sometimes they might do an injection, and then sometimes surgery, but there's a process through all that and time, and there's so many times people think I need to have surgery, and that might not actually solve it, and actually might make things worse, and it's sometimes 50-50 whether it might even help, where the physical therapy might be the best long-term solution for them. So get evaluated and make sure there's not something else going on too. But you've usually got some back pain and then this numbness or pain that radiates down the leg.
Yep, and that sciatic nerve is a big nerve. It's about the size of your thumb, and it tends to split a muscle in your butt in half, the piriformis muscle. So if that muscle is tight, or it can pinch down and pinch nerves, send pain signals. So if you can, a lot of times that's where the physical therapy is the first place where we talk with stretching, strengthening that muscle so it's not pinching down on that nerve and causing that pain. And that, in that case, surgery on your back would do nothing because that's not where the pain's coming from. So, all right, next question. After experiencing a TIA, I wonder how can I avoid future episodes? Again, let's start with definitions since there's acronyms in medicine. TIA.
Yeah, TIA, and the terminology around this is fluctuating, but people are pretty familiar with the term TIA, transient ischemic attack. Someone might have heard the term mini stroke that gets thrown around. So really that's symptoms of a stroke which resolve quickly without intervention, within usually hours. It's a very intelligent question because when I see my patient in my office after they've been in the emergency room with this, that's the exact question that I'm asking too. Really, the focus is on how do we reduce your risk of having another event? And it depends on, some diagnostics usually are warranted if this is the first event. So there's several reasons people can be at risk of stroke, and if someone has those reasons, we want to find them. So one reason might be plaque in the arteries that go to the brain. So we usually will look one way or another if it hasn't been done yet at the carotid arteries and see if there's any major disease there. We should look for atrial fibrillation in people who have TIAs or strokes. So that's an abnormal heart rhythm that puts you at risk of a blood clot causing a stroke, and that's a kind of a totally different treatment plan than your other more typical strokes. So it might mean wearing a heart monitor for a time if that hasn't been done yet. So some diagnostics are in order. Usually we'll do an echocardiogram if that hasn't been done for the same reasons. And then it's really about what we call secondary prevention. So depending on the cause, if we find atrial fibrillation, it's talking about an anticoagulant or a blood thinner. if we do find plaque disease, it's talking about a statin and usually an aspirin, or maybe if you're already on an aspirin, it's a more complex conversation. But it's medical treatment in most cases to reduce your future risk.
Excellent.
Controlling your blood pressure,
Yes.
controlling your blood sugar. Yes, and those are quitting smoking.
Yes.
Very, very important things.
Addressing those risk factors as well.
And those mini strokes, those TIAs, are a great opportunity to reduce that risk for an actual stroke. You're at higher, absolutely.
And you mentioned a statin. To clarify, that would be for cholesterol, so cholesterol medication.
Yep.
But in the setting of, if we find plaque here, I don't care what your cholesterol number is. Being on a medicine is important. So sometimes that's kind of hard to discuss with patients and cut through. But yeah, there's definitely things we can do that we know reduce your risk. So it's a great question.
Excellent. All right. A caller from Sioux Falls asks, what's the best way to clear a plugged ear? Lots of earwax. That's a very common. I won't tell you what my mother did when I was little.
I remember that the day that I was shadowing with Dr. Holm, him scolding a patient about using Q-tips. That was his soapbox, I feel like, against Q-tips, right?
Yes, Q-tips, bobby pins, don't.
So, a plugged ear typically means one of two things. It either means I've got a bunch of wax plugged up that's impacting, it's clogging my whole ear canal, or sometimes it means that the eustachian tube, which is kind of the ventilator that equalizes the pressure between the inside and the outside of the ear, between the front and back of that eustachian, or the tympanic membrane. So when you go up in the airplane and you need to pop your ears, it's that eustachian tube that has to open. So it could mean one or the other of those things. So Andrew, what do you tell your patients about earwax?
Leave it alone, and if there's an issue, to come in and we'll irrigate it, or sometimes I use a curette and take it out, or an ear, nose, and throat doc can do that. As far as the eustachian tube plugging up, antihistamines could be helpful. Maybe, depending if you don't have other risk factors, you could use a decongestant for a short amount of time. Or a steroid nasal spray can be helpful for Flonase or fluticasone.
Which is important to know is not going to work tomorrow.
Right.
You've got to use it consistently. It's a long-term thing. But Q-tips are never, ever, ever the answer.
No. I always tell patients, remember when they would do the old muskets and they'd put the ball in and then they'd jam it with their rod to pack it? That's what you're doing with the Q-tip. You are jamming that wax deeper and further in there.
The ears are self-cleaning. They naturally move that wax out, so don't push it back in.
I have some patients, if they have recurrent issues with wax getting dry, hard, and plugging up, that use some sort of oil. They put a drop of mineral oil in there every night just to keep it soft, and then it will more naturally work out.
I'll frequently
and that's safe.
recommend that to people, as long as their eardrum is intact.
Right. Or the Debrox over-the-counter drop. That's a dilute hydrogen peroxide. So. All right. Well, is 72 years old an okay age to recover and rehab from knee replacement surgery? Absolutely.
Jinx. That's a great age to do it.
That is a great age to do it at. You're still young enough to go dancing, and yes.
The age would not disqualify you by any means.
Absolutely not.
It's worth a conversation. I mean, the 72 can look very different on one patient versus another, depending on your other health factors and your surgical risk. But yeah, we see a lot of people in their 70s get joint replacements.
72-year-olds are actually probably on the young end of the people that I see come in wanting their knees replaced.
I've seen 80-plus-year-olds quite happy with some of their joint replacements.
Absolutely. So go talk to your doctor and go talk to the surgeon.
I've got an ortho show mid-October.
Perfect.
October 17th, I believe.
All right, tune in then.
Questions,
All right. What specialist should this person see to get tested for lupus? So that's another.
Yeah, I mean, I think lupus is a complex diagnosis to make. It's not like we have one test that does it all. It's actually, if you look at the American College of rheumatology guidelines for diagnosing lupus, it's a list of like 20 plus things, and you have to have so many in different categories. It's a complex diagnosis. Rheumatology is the expert. It's in diagnosing and treating lupus, of course. But I start with your primary care provider. I think always. There's some of those inflammatory and autoimmune conditions. There's a lot of kind of weird information online out there, so I always wonder why do you think you have lupus? So PCP is a great place to start, and certainly we refer people to rheumatology if we have a question about that.
All right, here's another very common issue. A patient has been dealing with plantar warts on their feet for 3 years. They've been going to a dermatologist and has done topical treatment, topical acid treatment, cryotherapy, antiviral cream, all of this with no relief. Any other options? They said injecting chemo into the wart or HPV vaccine. What would you guys recommend?
Like all these hard, difficult
it's such a
questions. It is a frustrating problem. It is, and the dermatologists say so too, right? Like the dermatologists say this is one of the hardest things we do because there's not a single cure for warts, unfortunately.
Persistence is key.
Yes.
And yes, you can switch up treatments, and sometimes at home I recommend putting duct tape on it for a week and then putting salicylic acid or compound W on it for a week and alternating. But if you can get the body's attention to the area, sometimes then the body will naturally start to reject it. And it can do that on its own without doing anything. But then if you're not doing anything, it's getting bigger and bigger and bigger, and it'll take longer and be harder for it to treat. So persistence of doing something, whether all of the various treatments from the dermatologist or whatever. But
have you guys ever tried Tagamet for that?
I've heard of that. Yep.
Yeah, Tagamet, and it makes no sense, and I don't understand. But Tagamet is actually an H2 blocker. It is a medicine that traditionally gets used as an acid-reducing medication. And I have had some luck, and it's one of those, the studies, but it's pretty harmless, and high-dose Tagamet. I've had some people have some success with it.
Are they taking the pill or are they putting it?
No, they're taking the pill.
Take the pill. Yep.
Which, again, it doesn't make any sense. I don't understand why
I think there is ongoing research about HPV vaccine as treatment for warts. I don't know that any of it has panned out as clearly positive. But
I've also done injections with Candida or yeast antigen. And again, the whole idea is to get your body to have something that's irritating, to get its attention to the wart and say, hey, come here and attack this. So
warts are caused by the human papillomavirus. So we have the HPV vaccine that we give to young people to protect them from the strains of the warts that cause genital warts and cervical cancer and certain other types of cancer. But the types of HPV virus that cause the plantar warts, the warts on your skin, are usually a different strain. So I tell people saying HPV is kind of like saying dog. It could be a Bichon fish, it could be a lab, it could be, and different virus, different dog breeds do different things. So different.
But they can be a bugger. I mean, it's
really
not your fault.
It's not your fault.
Very frustrating. And even in residency, one of the docs there was doing research on hypnotherapy with that, to imagine your body, going down and attacking the warts in a little spaceship. So it was fascinating.
Makes as much sense as Tagamet. What can I say?
Well, we are coming to the end of our show here, so we will be right back after this.
On Call with the Prairie Doc has been a leading source of health education for 22 seasons. Join us this season as we continue to provide health education based on science, built on trust. Follow us on Facebook, Instagram, YouTube, and TikTok to access the entire Prairie Doc library.
Well, thank you to our Prairie Docs, Dr. Ellsworth, Johnson, Evans, and me, for volunteering their time to answer our viewers' questions. If you would like to see and hear more episodes of this program, please like and follow us on Facebook, Instagram, YouTube, Threads, and TikTok, or visit us at prairiedoc.org. Look for Prairie Doc Perspectives in your local newspaper and online. Listen to us on Prairie Doc Radio on SDPB Sundays at 6 a.m. and 1 p.m. And be sure to look for the 2 Prairie Doc podcasts wherever podcasts can be found. Well, from all of us here at On Call with the Prairie Doc, thanks for joining us for another episode of health information based on science, built on trust. Until next time, stay healthy out there, people.
Whether children are adopted internationally, domestically, or through foster care, all are at increased risk of having short and long-term medical conditions. Adoption and foster care. Next time on Call with the Prairie Doc.
My name is Dr. Tom Dean, and I serve on the Healing Words Foundation Board, the nonprofit organization that runs Prairie Doc programming. Our mission is to enhance health and diminish suffering by communicating useful, science-based information respectfully and compassionately. Your donation supporting Prairie Doc programming makes an extraordinary difference. Gifts of any size enhance its impact in our state and beyond. Thank you for your generosity.
Major funding for On Call with the Prairie Doc has been provided by
At Avera, our nationally recognized health system will be right here with you with care and coverage. Hello possibility. Hello healthy. Hello life. Avera, moving health forward.
Larson Manufacturing is proud to support On Call with the Prairie Doc as it continues to open doors for important medical information. And with the ongoing support of these individuals and institutions, Brookings Health System, South Dakota Academy of Family Physicians, Ophthalmology Limited, Avera Medical Group Brookings, Avera Heart Hospital, First Bank and Trust, Dakota Allergy and Asthma, Monument Health,